Hello everyone! In the previous lesson, we explored the red blood cell indices and we introduced how to classify anemia and think through possible causes. In this video, we will take it a step further. We will analyze the clinical cases and work through how to identify the underlying cause of the isolated anemia using the CBC as supporting clues. So now let's begin our lessons. Alright, let's read the CBC results together. First, we look at the MCV and the MCX value. The MCV is 74 femtoliter and the MCX is 23 picograms. So, this is the microcytic hypochromic anemia. Now, when we see this pattern, what is the most important cause? The most common causes include iron deficiency anemia, thalassemia, and anemia of chronic inflammation. So, what is the next step? We don't stop here. We need to look at the clinical features like symptoms, history, and some kind of chronic illnesses. And most importantly, we need to run some iron studies, especially the ferritin level and the serum iron level, to narrow down the cause. Before we go further, let's take a quick review. What is the main function of ferritin molecule in the human body? You should think about the answer. We have 4 answer choices. Yeah, the correct answer is B, to store iron in our body. Ferritin is the main intracellular iron storage protein. It helps us to keep the iron safely stored and ready for use when needed. So when we check the serum ferritin, it reflects the body iron stores, and that is very important in diagnosing iron deficiency anemia. Now, let's talk about how to interpret the iron study or the iron profile in microcytic and hypochromic anemia. When we see the low ferritin, it strongly suggests the iron deficiency anemia because the ferritin reflects the iron stores. On the other hand, if our ferritin is normal or even increased, iron deficiency is much less likely. In this case, we should consider thalassemia or the anemia of chronic inflammation. So now, what is the next step? To differentiate between the thalassemia and the chronic inflammation, we can look at the serum iron. It's usually normal or high in the thalassemia but low in the chronic inflammation. However, sometimes it will be struggling because the serum iron is affected by many various factors like the food or some kind of iron supplement. And finally, to confirm the thalassemia, we need to order hemoglobin electrophoresis. Now, let's walk through this clinical case together. We have 40 years of woman, a farmer, who presents with fatigue. She has a history of menophasia, heavy menstrual bleeding likely due to the uterine fibroids. She also hasn't been dewormed, and she works in a rural environment, so hookworm infection is definitely a concern. On physical examination, she appears pale, which supports our suspicion of anemia. Now let's take a look at the lab results. Analyze the result reveal that this is a case of microcytic and hypochromic anemia. And when we see this pattern, we usually think about 3 common causes: the iron deficiency anemia, thalassemia, and chronic inflammation. Then, how do we narrow it down? The patient had a chronic blood loss from the menophasia, and she is a farmer and she has no deworming history, so helminth infection is also impossible. Both of these factors point strongly toward the iron deficiency anemia. What is the next logical step? We should recommend an iron profile, and in this case, the test was ordered, and her serum ferritin result is 9 microgram per milliliter. That is a key result. Remember, ferritin reflects the iron storage in the body, and when the serum ferritin drop below the 15 nanogram per milliliter, it becomes strong evidence of the iron deficiency, especially in the patient who already has the anemia. So, everything points to one clear diagnosis: iron deficiency anemia in this case. Okay, now let's walk through this next clinical case. We have an 18-year-old female who was previously healthy, now presenting with 1 month of fatigue. On physical examination, she also appeared pale, supporting our suspicion of anemia. But there are two additional findings: scleroderma, or the yellowish eye, with a mild splenomegaly. These findings raise concern for the hemolysis and extravascular red cell destruction. But now let's take a look at the lab results. Analyze the result revealed. This is the case of microcytic and hypochromic anemia like we mentioned before. And when we see this pattern, we also have to think about 3 common causes: iron deficiency anemia, thalassemia, as well as the chronic inflammation. And now, how do we narrow it down? First, this is a young patient, 18 years old, who were previously healthy. And there is no obvious source of iron loss like the menophagia or the malnutrition. But she does have the mild splenomegaly and the yellowish eye, signs that point toward chronic hemolysis. That strongly suggests that thalassemia is the most likely cause. So, what is the next logical step? We order an iron profile to rule out iron deficiency, and we order the hemoglobin electrophoresis to confirm the diagnosis of thalassemia, because thalassemia is the hemoglobin disorder, remember. Okay, now we have a next case. A 68 years old male who's been admitted to the respiratory department. He has a history of chronic cough and was recently diagnosed with pulmonary tuberculosis. And important details: on examination, he appeared pale, and you can hear the pulmonary rouse or the auscultation. Notably, there is no hepatosplenomegaly. Now let's take a look at his CBC result. When we analyze the result, we reveal that a case of microcytic and hypochromic anemia due to his MCV and his MCX is lower than the threshold. When we see the microcytic hypochromic anemia, we again think about 3 main causes: IDA, thalassemia, and the chronic inflammation. And so now we need to narrow it down. Let's think logically. He's an adult he's an older adult hospitalized with a chronic infectious disease of the tuberculosis, which causes the persistent systemic inflammation. There is no history of the blood loss or dietary deficiency to suggest the iron deficiency. And the thalassemia would be unusual at this age without a prior diagnosis. So what is the most likely cause? That is the anemia of the chronic disease due to the chronic inflammation. So now what is the next step? We check an iron profile, and in this case, his serum ferritin level is 325 nanogram per milliliter. That's well above normal, which essentially rule out iron deficiency. Because, remember, ferritin is also an acute phase reactant, and it increases with the inflammation. So, we land on the most likely diagnosis, anemia of chronic disease, secondary to the tuberculosis, or some kind of anemia of chronic inflammation. Now let's explore why chronic inflammation can lead to the microcytic hypochromic anemia. First, let's start with the trigger. Chronic inflammation causes the immune system to release the cytokines, especially the interleukin-6. Interleukin-6 acts on the liver, stimulating the production of hepcidin, a key regulatory hormone for iron metabolism. What does the hepcidin do? It inhibits the iron absorption in the duodenum, as well as it blocks the release of the iron from the macrophages and the liver stores. That means even though there may be iron in the body, it can't be used. It's trapped. So, what is the result? Decrease the iron available for transport in the blood and reduce the iron delivery to the bone marrow where the red blood cells are made. And that leads to the microcytic hypochromic anemia because the bone marrow can't synthesize enough hemoglobin. But there is more. Chronic inflammation also reduces the erythropoietin production. That's the hormone from the kidney that normally stimulates the red blood cell production. So now we have both iron restriction and reduced stimulation of the bone marrow. The combined effect is a low-grade persistent anemia known as an anemia of chronic inflammation. Okay, now let's turn to the next case. We have a 70-year-old woman with rheumatoid arthritis, currently on the NSAID therapy. She presents with fatigue and loss of appetite. On the examination, she is pale, but there is no hepatosplenomegaly. Now, let's take a look at her CBC result. Analyze the result. Reveal that this is the case of the macrocytic and hypochromic anemia. As we discussed before, the pattern suggests the iron deficiency anemia, the thalassemia, and the chronic inflammation. Now, let's reason through this. The patient had the chronic inflammatory disease, the rheumatoid arthritis. So anemia of inflammation is certainly possible. But, and this is also important, she also on the NSAID therapy, which we know can cause the gastric ulcer or bleeding. So that at this point, the CBC and the clinical history can't fully distinguish the cause of the chronic inflammation as well as the iron deficiency anemia. So what is the next step? We need an iron profile to help us to differentiate. And here's the key finding. Her ferritin serum, her serum ferritin is 10 nanogram per milliliter. Remember, when the level of the ferritin is below 15 nanogram per milliliter, is strong evidence for iron deficiency, even in the context of the chronic disease. So the low ferritin clinches the diagnosis. Final conclusion. This is the case of iron deficiency anemia likely due to the chronic blood loss from the NSAID-associated GI irritation. Okay, now let's move to the next case. We have a 28-year-old woman, currently 20 weeks pregnant, who hasn't been attending regular checkups. The pregnancy appears healthy, and the doctor recommends a routine complete blood count. Now let's look at the CBC result. Analyze the result reveal that this is again a case of microcytic and hypochromic anemia. And we already know we will think about three common causes: IDA, thalassemia, as well as the chronic inflammation. Let's think about this patient. Chronic inflammation is less likely. She is young and has no non-chronic illness and shows no sign of systemic inflammation. Now, the link that leaves us with the iron deficiency, anemia, and thalassemia. Here's where it gets tricky. Pregnancy, especially during the second trimester, is a stage where the iron demand increases significantly. And many women may already have the low iron store before. So iron deficiency is common and very common in pregnancy. But here is also the challenge. Some thalassemia trait and minor also present microcytic hypochromic anemia and may be mistaken for the iron deficiency. And these patients, both are plausible. She is pregnant, but her RBC count is relatively high, which raises the question of the thalassemia. So what is the next logical step? We need more data specifically, an iron profile, and a hemoglobin electrophoresis. In this case, the iron profile has been done, and her ferritin level is within the normal range. That means her iron stores are not depleted. So, the likely diagnosis here is the thalassemia trait or minor, not the iron deficiency. And that brings us to an important point. Although the patient does not need the iron supplementation, the result opens up on another clinical concern, especially in the context of the pregnancy. If the mother carries the thalassemia trait or minor gene, there is a chance that the fetus could inherit a severe form of thalassemia, especially if the father also a carrier. So at this point, the appropriate next step isn't treatment, but screening. We should offer genetic counseling and consider screening for the father, for the thalassemia trait or minor. This is a critical part of antenatal care in regions where the thalassemia is prevalent. Alright, so now another CBC result. First, please check at the MCV as well as the MCX. The MCV is 112 femtoliter. It's above 100. So this is the macrocytic anemia, right? Okay, and whenever we see the macrocytic anemia, there are few key causes we need to consider: vitamin B12 or folate deficiency, reticulocytosis due to the acute hemolysis or recent bleeding, or some even chronic liver disease. So what is the next step? We don't stop at the numbers. We need more context. Check the clinical features. Then recommend further tests, especially a reticulocyte count and a peripheral blood smear. They can really help us to differentiate between the causes. We will talk about how to interpret those in the next slide. To figure out why the red cells are large, we don't just rely on the CBC test. We need two more tests: a peripheral blood smear or a reticulocyte count. Let's start with the smear first. If we suspected a problem with the nuclear division, like the vitamin B12 or the folate deficiency, we look for the classic sign, the hypersegmented neutrophil. You can see it here, more than 5 lobes in the nucleus. Now, what if we think the macrocytic is not due to the nuclear division, but due to the increase of the reticulocytes, like after hemolysis or bleeding? So, we confirm that by ordering a reticulocyte count or percentage. And as you can see in the image, they stand with this bluish speckled appearance. Each of these tests point us in the different direction, and help us find the real cause behind the microcytic anemia. Okay, now let's begin with the cases. We have a 57-year-old woman who has been a vegetarian for many years. She comes in the fatigue and a poor appetite. On exam, she looked pale and there is no hepatosplenomegaly. So, our first step is to interpret the CBC result. Her MCV is 118 femtoliter. That is clearly above the 100. So this is the macrocytic anemia. Now, we move to the next step. What are the possible causes of the macrocytic anemia here? We usually think of the B12 and folate deficiency, the hemolysis or the acute bleeding, and the last one is the liver disease. But how do we narrow it down? Let's look at her history. She's been the vegetarian for a long time. That's important. And vitamin B12 is found mainly in the animal products. So dietary deficiency is a real concern in her case. So now, what is the next step? We order two things. The peripheral blood smear to look for the hypersegmented neutrophils, and a B12 and a folate panel to confirm the deficiency in levels. Everything here points us toward the megaloblastic anemia, and this is exactly how we approach it clinically. Here's a case I want you to think through carefully. A 25-year-old woman, previously healthy, was admitted after a traffic accident. She had a tibial fracture and underwent the surgery. Now it's day 3 of her post-operative period, and the team ordered a complete blood count. Let's start with the basics. Her MCV is 106 femtoliter. That's a macrocytic. And now we ask, what causes macrocytic anemia in someone like this? Think about the context. She's young, no chronic illness, but she just had the surgery and trauma. That raises a possibility: is her bone marrow responding to acute blood loss? In early stages of recovery, the bone marrow increases red cell production, and in doing so, it releases more reticulocytes, which are larger in size. That can push the MCV upward, giving a transient macrocytic picture. So now, what do we do next? We check the reticulocyte percentage or count. If they elevated, it confirms her marrow is working hard to compensate and explain the macrocytosis without needing to consider all the causes like B12 or liver disease. Here's what the reticulocytes look like under the microscope. Reticulocytes are mature red blood cells recently released from the bone marrow. We will explore more about when and why reticulocytes increase shortly, and why the reticulocytosis would cause an increase in the MCV value of the CBC result. Take a closer look at the reticulocytes and how they relate to the red cell production. To produce healthy red blood cells, the body needs 3 key components: materials like iron, vitamin B12, and folate. Erythropoietin, the hormone that signals the bone marrow to make more red cells. And a functional bone marrow, the factory that actually makes them. When everything works well, red blood cells are produced steadily. After maturing in the bone marrow, they release to the circulation at the reticulocytes, slightly larger immature red cells that still contain RNA meshwork. And here is the important clinical insight. Reticulocytes are some quite bigger than normal red cells. And so when you have a lot of them, like hemolysis or after bleeding, they push our MCV upward. That is why one possible cause macrocytic is reticulocytosis. Even though the red cells themselves are normal in size once they mature. So what caused the increase of the reticulocyte count? The first one is acute blood loss, the second is the hemolysis, and the fourth one is the recovery after treatment or deficiencies. And our bone marrow regenerative after suppression. And what causes the decrease the reticulocyte count? Erythropoietin deficiency lies in chronic kidney disease. Nutritional deficiencies, iron, B12, and folate deficiencies, or bone marrow failure due to aplastic anemia, leukemia, and metastasis. In summary, when you see the microcytic anemia beyond the B12 and the folate, you should check the reticulocyte count. It can point you toward a very different mechanism. And now let's turn to this case. We have a 54-year-old man with a history of alcohol addiction, presenting with the jaundice. On physical exam, he is pale, has a yellowish eye, right upper quadrant tetanus, and hepatomegaly. So there is a clear concern for the chronic liver disease. Now, let's interpret the CBC result. The MCV value is 110 femtoliter, which is above 100. So this is the macrocytic anemia. So now let's remember. What are the typical causes of the macrocytic anemia? B12 or folate deficiency. Reticulocytosis due to from acute blood loss or hemolysis. And the final one is the chronic liver disease. Then, now do we narrow it down? This patient had no sign of bleeding and has no history suggesting nutritional deficiency. But he does have the alcoholism, jaundice, and hepatomegaly, all strongly suggest the chronic liver disease. So, what is the next step? We still need to rule out all the possible causes, and for that, we will check for the peripheral blood smear to look for the hypersegmented neutrophils, abnormal cells. And we also have to check the reticulocyte count to accept whether the bone marrow is responding with the anemia. And of course, liver function tests to confirm the impact of the liver dysfunction. So far, all signs point toward the macrocytic anemia is secondary to the chronic liver disease. Alright, before we wrap up this section on the red cell indices, let's go through a quick review of questions together. Take a moment to read the questions on the screen. Which of the following causes microcytic and hypochromic anemia with the low reticulocyte count? And now let's walk through this. First, the microcytic hypochromic anemia tells us that the red cells are small and pale, meaning they are low in hemoglobin. That already helps us to eliminate the B12 deficiency, as well as the bone marrow disorders. And now, the thalassemia does cause the microcytic anemia, but the reticulocyte count is often normal or high because the bone marrow is trying to compensate. So, our best answer here is the D, and the iron deficiency anemia. And it causes the microcytic hypochromic anemia with the reticulocyte count is low because there isn't enough iron to support the new red cell production. And now, normocytic and normochromic anemia can be tricky to interpret because it has many possible causes and often needs all the clinical or lab data for proper evaluation. That is why I won't walk through it as a separate section today. Instead, you will see it again embedded in the future clinical scenarios. We have just finished analyzing several cases of isolated anemia, learning how to interpret red cell indices and connect them to likely causes. In the next video, we will shift our focus to the other two important cell lines, the white cells as well as the platelets. Okay, now see you in the next session. See ya. Thank you for watching.